Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. Today we're going to be talking about status epilepticus. If you've ever seen anyone go into a convulsion or have an epileptic episode, it's a very scary thing to see, especially in children. For the final year students, this is a very important topic because medical emergencies or even emergencies in any of the departments are important for you to know because you're going to be dealing with them. I pray you do not because it's a very unsightly thing to see. And for the fifth year, this is a very important topic for you to learn because it's setting the foundation as you are going towards your final year. For the people that still haven't had any functional knowledge on seizures as well as epilepsy, we shall make a separate video on the channel to cover these topics, especially in pediatrics. If you still haven't yet subscribed to the channel, please subscribe to the channel, drop a like, drop a comment to show that you are enjoying these videos, and grab your notepad and let's go. So remember that status epilepticus is pretty much a medical emergency. Now, if you were to recall the definition of a seizure, this is just simply going to be an abnormal, paroxysmal, excessive firing of the cerebral neurons that's going to be involving transient loss in consciousness or alterations in consciousness. It may or may not. There may be some behavioral changes. There may be some motor activities. There may be some sensation or even autonomic functions. Now, remember, seizures differ from convulsions. You could think of a convulsion as an outward manifestation of a seizure. Most of the times people use these terms interchangeably, but they do not really mean the same thing in essence. So if you are talking of a convulsion, it's pretty much what you are seeing is happening to this patient. If they're having this violent jerking of the upper limbs and the lower limbs, you refer to that as a convulsion. The activity that is actually happening in the brain, you refer to that as a seizure. And remember, if you have a person coming with a seizure, just one seizure, and that's it, you do not want to start them on anti-epileptic drugs there and then, because I had a professor, or rather a lecturer, that used to say everyone is guaranteed at least one seizure in their lifetime. So it means that you do not just instantly start them on anti-epileptic drugs. And then the difference between just a mere seizure and epilepsy is that with epilepsy, this is going to be the occurrence of two or more spontaneous seizures without any obvious precipitating cause. So these are usually unprovoked. That's the underlying thing. That's the key thing, is that epilepsy, they are going to be unprovoked. So remember now, when we're talking about status epilepticus, this is a complication, or this is rather a progression of a seizure. So you get this individual that's going to be having a prolonged single seizure, or they could be having multiple seizures that are lasting more than 5 minutes without them regaining consciousness in between. So way back, we used to use a threshold of 30 minutes, and then it was reduced to 20 minutes, and then at one point it was even at 15 minutes. But what we've realized from most of the research is that if the seizure doesn't really stop within 5 minutes, then it's unlikely for the seizure to stop. So you could classify this child as having status epilepticus. So you could think of it as a seizure that's just lasting more than 5 minutes, or you have recurrent seizures that are close to each other such that this child does not have any consciousness in between these seizures. And remember that the problem of this person having these recurrent or continuous seizures is that you're putting the brain at risk of developing hypoxia. So the brain goes without oxygen for some time, and this could actually bring about certain complications that we'll talk about. And remember that the risk of complications substantially increases with the duration. So if you get someone who's seizing recurrently for more than an hour, then this puts their brain at a very high chance of being hypoxic, and they may develop other complications later on in life. Now, how do we classify status epilepticus? We could classify it into two main types. You have the convulsive type. These are pretty much motor manifestations that we're going to be seeing. These are very common and they're going to be associated with significant morbidity as well as mortality. Then you have the non-convulsive type, which are pretty much absence type of seizures, non-convulsive seizures, even speech sensorial alterations. But with the convulsive type, which is what you're obviously going to be seeing on the wards, there may be tonic-clonic, where the whole body is just going into these repetitive contractions and relaxations, especially with violent jerking of the upper limbs as well as the lower limbs. So you could have a clonic type of seizures where the muscles of the body are just stiff, then myoclonic, where a group of muscles are just contracting. But the most common type that you shall see on the wards are obviously the tonic-clonic seizures. Remember that absent seizures are also pretty common in children that are going to be manifested just by this blank stare into nothing, where this child is absent-minded. So keep a look out for that. It will manifest as a child's decline in their activity at school. So there are certain causes that may result in an individual having seizures, and these are the common causes that are going to be causing status epilepticus. So you could divide them into infectious causes as well as non-infectious causes. So for the infectious causes, it could be encephalitis or whatever may be causing the encephalitis. It could be viral encephalitis or even bacterial encephalitis, or meningitis, whatever may be causing the meningitis, viral meningitis, or bacterial meningitis. Of course, if you have a known epileptic child that has these intercurrent infections in between, then it may predispose them to present with status epilepticus. You may also have some non-infectious causes, so things like you get an epileptic patient that is not really taking their drugs as they should, so there's non-compliance. Either the mother is forgetting to give the child the medication, or in the adolescents they may forget to actually even take this medication. In some cases, this may actually be the initial presentation of epilepsy. They may also have some congenital malformations of the brain. There may be some metabolic as well as electrolyte abnormalities, things like hypocalcemia as well as hypoglycemia. In adolescents especially, you have to watch out for drug intoxication, especially with amphetamines as well as cocaine. You have also other things such as Reyes syndrome. Remember, Reyes syndrome is where you give a child aspirin after they have a viral infection, then they develop this complication, which is going to be affecting the neurological system. Sometimes the child may have lead intoxication or lead poisoning. They may sometimes be extreme hyperpyrexia or even brain tumors, though not so common in children. And if it is indeed a brain tumor, it is most likely going to be a glioma, because those are the most common type of tumors in children. Now, in the pathophysiology of the condition, there is two proposed mechanisms that have been postulated. So one mechanism is that there's going to be excessive as well as persistent excitation of the neurons in the cerebral cortex. The other thing is that there's going to be inactive recruitment of the inhibitory neurons. Remember that the excitatory neurotransmitters are going to include glutamate, aspartate, and acetylcholine. And then the inhibitory neurotransmitter predominantly is going to be GABA aminobutyric acid, or GABA. But what has been really implicated as the most important cause of status epilepticus is that you're going to be blocking these N-methyl D-aspartate channels, or NMDA channels, that are blocked by magnesium ions. Remember that NMDA channels are pretty much these channels found on excitatory neurons. So when they open, they are supposed to allow things like glutamate to be transmitted across the neuron. And remember that whenever someone is going into status epilepticus, there's going to be some hypoxia, there's going to be some hypotension, there's going to be some acidosis, there's going to be some hyperpyrexia, which may also exacerbate the neuron damage that may be there. When you're evaluating a patient that has status epilepticus, it is very important to take a history. But of course, we're not going to be starting off with the history if they come in seizing. You first want to treat the patient, then take a history afterwards. But of course, if they have already been treated, then you could decide to take the history now and get a detailed history. So you want to ask for things like the events that happened before the seizure. What was the child doing before the seizure? So that you refer to that as the pre-ictal phase. What was the child doing during the seizure? What were the movements that were there during the seizure? And then what happened after the seizure? Was there any confusion? Was there any urinary incontinence? Was there any fecal incontinence? Did this child have a fever? Then you ask for any other associated symptoms that may be there. Sometimes there may be other features of other diseases, such as this child may have other non-specific features that may point towards malaria. This child may sometimes have other non-specific features that may point towards meningitis, or even specific features that may point towards meningitis. You also ask for the duration of the seizure, because this is very important. The longer the person is seizing, the greater the chance of hypoxia to the brain. Then you want to ask for the history of a prior history of seizures, and if they have been found with epilepsy, as well as a family history of epilepsy, or anyone in the family that has had a similar problem. You also want to ask if they are taking anti-epileptic drugs. If they are indeed taking anti-epileptic drugs, ask them which drug they are taking, what dosage, and how often are they taking it, and are they actually taking the drug. This is going to help you in assessing the compliance. My rule of thumb is this: if someone has a chronic illness and you ask them what drug they're taking and they have no idea what drug they're taking and they don't seem actually interested in that drug, it's most likely that this person is not really into their health. Of course, this is not one key works for all those type of mechanism, so use it at your own peril. So I usually think that if someone has a condition, they would take it up to them to learn more about their condition and learn more about whatever they're taking for a really long time. But of course, the levels of literacy vary greatly across the patients that you're going to be seeing. And then you also want to ask them if they have changed the anti-epileptic drugs, if they have been taking them. You also ask them for any triggers that may be triggering these episodes, like for example in adolescence, if they have started drinking or smoking. Then you also ask for any history of prior neurological developmental abnormalities, and take note that if the post-ictal confusion still persists, then you have to search for other causes. So you have to look out for hypoglycemia. You have to look out for electrolyte imbalances. You have to look out for CNS infections. You have to look out for CNS vascular events. You have to look out for drug toxicities, even some psychiatric disorders, as well as a non-convulsive status epilepticus, of which we want to do an EEG or an electroencephalogram. Then you also want to examine your patient, perform a full neurological examination, search out for any focal neurological deficits, and if there are some focal neurological deficits, that's why you want to push to actually get imaging for this patient, because you may actually find something wrong in the brain. You may localize something in the brain. But if there is a normal neurological examination, then I don't see it as a first thing to do, ordering neuroimaging unless otherwise. But what you want to do is you want to order some blood investigation. So you want to order a full blood count or a complete blood count. Of course, order with a differential count. You want to look out for your white blood cell count. It may be raised, and then the differential count will give you an indication of whatever may be causing this. That's of course if this child also has a fever. You want to do your random blood sugar, because hypoglycemia can also trigger this child going into seizures. You also want to do an RDT, or rapid diagnostic test, for malaria, as well as a malaria parasite slide if this person has had a fever or has had hints that are pointing towards malaria. For example, they traveled to a malaria endemic place and then they started manifesting with these symptoms when they got back. Then you also want to order urea and electrolytes such as calcium, magnesium, phosphate. You can also add potassium and sodium to that list. You also want to check for creatinine for obvious reasons. If there are toxins and the kidneys are failing, the toxins accumulate in the body, then this may actually result in uremia, and this may actually trigger status epilepticus. You also want to order for some liver function tests, because if the liver is not also working, this may predispose this individual going into a hepatic encephalopathy, though not so common in younger children, but very common as the child gets much older. You may also order for your arterial blood gases if they are available, which may point you towards some acidosis that may be there. Sometimes you may order some serum lactate if it is possible. Then you want to do your CSF studies. If you're suspecting that this child has a meningitis, you can actually pick this up from your CSF studies. You also want to perform some neurological imaging. Of course, this may reveal some neuroinfections. You may have some neurological cysticercosis. Sometimes you may see head trauma. You also may see some malignancies. You may see meningoencephalitis. Sometimes you may make a diagnosis of neurometabolic disorders. And take note that we do not routinely do the electroencephalogram or the EEG. We only recommend it in patients that have status epilepticus and you're suspecting that it's a non-convulsive state, because with the convulsive state, you can pretty much see that this child is convulsing. And obviously, the EEG will have so little bearing on how you're going to be treating this patient. Possibly maybe localizing the origin of the seizure. That's what the EEG would help you do. So when it comes to the management, this is the most important aspect of this condition, because you have to do something about this. This is an emergency, so please ensure that you call for help. If you have no idea what you are doing, please inform your senior and inform anyone that's around you to come and help you out. So the goal of therapy is that you want to ensure that this child has adequate vital signs, as well as a systemic, as well as a cerebral oxygenation. We want to terminate the seizure. We want to prevent the seizures from happening or recurring, and we want to establish a diagnosis for this child, because the underlying thing, or the most important thing about correcting this, is removing the underlying cause. If the underlying cause has been corrected, then the seizures will abate. If the underlying cause is not there, it's like or has not been addressed, it's like sweeping the problem under the rug. The problem is still there. So what are the steps that we're going to be taking? So please pay close attention to this, because it will help you save so many lives and so many children when they come in seizing. So you want to do your ABCs. So you want to establish and secure an airway. So if there are any secretions, please suction the secretions. If the child is actively seizing, please turn them to the left lateral decubitus position to prevent them from aspirating. Then you want to ensure that this patient is breathing. So give them oxygen by a nasal cannula or a face mask. Assess if there's any need for endotracheal intubation. You want to gain venous access, probably 2 IV accesses. You want to send blood for labs. You want to administer dextrose and perically. So with patients that are seizing, we always assume that they are hypoglycemic. And we want to give them dextrose. We want to give them a 10% dextrose IV stat, and then we give them an infusion afterwards. We generally want to avoid boluses of dextrose because it may cause rebound hypoglycemia, if hypoglycemia is indeed the cause. And then we want to administer some drugs to abort the seizures. So how do we give the dextrose? We're going to be giving 10% dextrose at a dosage of 5 mils per kg intravenous stat. So if a child is weighing 10 kg, that means they're going to receive 50 mils of 10% dextrose. And then after that, you can give your 10% dextrose infusion over 4 to 6 hours. We obviously want to measure or monitor the systolic blood pressure and keep the temperatures normal. If this child has hyperthermia, you want to treat the hyperthermia accordingly. Then when we're aborting the seizures, we want to use certain drugs. So we're going to start off with your benzodiazepines. So we're going to give this child either diazepam or lorazepam. Lorazepam is usually the drug of choice, but I haven't seen it in most hospitals locally because I think this drug is much expensive and diazepam is readily available in almost every hospital. So the drug of choice is going to be your lorazepam, because lorazepam does not suppress the respiratory centers as much as diazepam does. And we could give this lorazepam at a dosage of 0.1 milligram per kg, and usually it has a longer duration of action as compared to diazepam. Then if you're given diazepam, which is the usual thing that we give it at if we're giving it intravenous, we're giving it at 0.3 milligrams per kg as a stat dose. If we're giving it rectally, if this child doesn't have a cannula, then you're going to be giving it at 0.5 milligrams per kg. And if this person still keeps seizing, you want to repeat this after 5 to 10 minutes. And of course, your maximum is 10 milligrams. And if they are still seizing after this, and you have given the second dose of diazepam, you can now start with your phenytoin. So you're going to be giving phenytoin at a loading dose of 20 milligrams per kg, which is obviously going to run at 20 in 20 minutes. So you're going to give a maximum of 50 milligrams per minute, and of course you're going to be giving this in saline. You do not want to use dextrose to dilute your phenytoin because dextrose is going to precipitate phenytoin. So you want to use saline when you're diluting your phenytoin. And then of course you should see an effect, a therapeutic effect, in about 20 minutes. For the final year students, they usually bother you about learning about side effects of drugs because you should be able to pick these up when you see them in the child. So phenytoin could result in hypotension, it could cause cardiac arrhythmias, it could cause phlebitis, it could cause tissue necrosis when it extravasates from the blood vessels, it could cause some movement disorders, even cerebellar ataxia. And in case where this child now, you've given benzodiazepines, you've given phenytoin, and they still aren't responding, and I presume by this time you would have already informed your senior, then you're obviously going to be giving them phenobarbital or phenobarb. That's going to be given intravenous with a loading dose of 20 milligram per kg and given at a rate of 2 milligram per kg per minute. And you obviously after that give a maintenance dose of 5 milligram per kg once a day or in 2 divided doses. And take note that in older children, we're going to be using a phenobarb after we give the benzos or the benzodiazepines after diazepam. But in neonates, it's a bit different. So in neonates, you want to start off with phenobarb first. So in treating neonatal seizures, we want to use phenobarb. If someone has some cardiac conduction anomalies, because remember you said that phenytoin can cause some arrhythmias, so we want to use phenobarb. If someone has hypersensitivity to phenytoin, we want to use phenobarb. And you also have to take some caution in especially patients that have already received benzodiazepines when you're adding phenobarb, because it can depress the respiratory centers. So this has to be looked out for. Another drug that could be given is paraldehyde, though I haven't seen this being given routinely. I haven't even come across this drug locally. So we could administer this rectally, about 0.3 mils per kg. We dilute it in a ratio of 1:3, or you could give it intramuscularly. And remember that when you're giving paraldehyde, this should be given in a glass syringe because it's going to dissolve plastic. It's also going to dissolve rubber. Then if this child still is seizing, by now you should have already informed your seniors, and your consultants should also even come in, and the much more experienced medical personnel should be dealing with this case. So if this child is still seizing and you can't control this, they may be put in a barbiturate coma. They may have diazepam or midazolam infusions. Sometimes they may be given intravenous sodium valproate. They may be given sodium thiopental. They may sometimes use inhalational anesthetics to actually abate the seizure. And remember that this should be done in the pediatric intensive care unit, where you have all these facilities that are going to provide artificial ventilation for this patient. And the most important thing about treating seizures is you want to look for a cause, an underlying cause, and you want to treat this underlying cause. So here's a management algorithm. So you have a child that comes in fitting, so you want to check that the airway is patent. You want to give high flow oxygen. You want to do a random blood sugar. If the blood sugar is below 3.5 millimoles, you want to give 5 mils per kg of 10% dextrose. If you do not have facilities to check for the random blood sugar, always assume that this person is hypoglycemic. So you want to give them that. If they are unconscious and you can't put an IV line, you can actually give it via a nasogastric tube. You can insert a nasogastric tube. So if they have a cannula, then you could give diazepam 0.3 milligrams per kg IV. If they do not, you could give this at 0.5 milligrams per kg rectally. If they continue, then you repeat the dose after 10 minutes of the same 0.3 IV or 0.5 as a rectal dose. And then if they still seize and they still continue after the second dose of these, then you could give them your either your phenytoin, and then if they don't respond to that, you could load them with phenobarb, about 20 milligrams per kg IV slow infusion over 20 minutes with a maximum dosage of 1 gram. And then if the seizure actually continues, like I told you, consult your senior, because this is most likely that it's not going to abate. And take note that this management algorithm is for patients or children that are greater than 1 year old, because management in neonates is a bit different, so we shall cover that separately as a topic on its own. So some complications that may be associated with seizures: you may have learning disabilities. Please desist from using the term "this child has mental retardation," so we want to refer to them as learning disabilities. This child may also have some focal neurological deficits. This child may have some behavioral disorders. Sometimes this may be chronic epilepsy. Thank you for taking your time to listen to this review lecture on status epilepticus. Please stay tuned for more of such videos on the channel. If you like this video, subscribe to the channel, drop a like, drop a comment, show some support. Until next time, bye bye.